Hello, my name is Andrew Merritt. I'm a orthopedic surgeon at ProLiance Orthopedics near Seattle. I'm starting a series of talks to help learn about the ACL. This is one of the most critical things that we deal with in athletes of all ages, especially young, and a big part of my practice. And I think that it's very important for patients, whether you're getting care with me or elsewhere, to know about their injury and to understand what is going on. And so this is an overview video of ACL surgery, injury and surgery, and then dive in more in detail about the ACL in future videos. So first of all, ACL tears, we hear about it all the time. You turn on ESPN, you watch the NFL season, you see ACL injuries all of the time. And so it's definitely a big part of sports. And so we're going to talk about what it is and why it's important. So this is the model I use a lot in clinic to show patients. This is a knee model looking from the front. It shows the majority of the structures of the knee, including the MCL, the LCL. But what we can look at is the inner side of the knee. So I have to move the kneecap to the side, and we see the inside of the knee, which this is the ACL, okay? There's also a PCL in the back that you hear about sometimes. The ACL is this front ligament that crosses across the joint from the front of the tibia to the end of the femur. And it has main function in sports of stopping the rotation of the knee. So when the foot is planted and the body turns, the knee wants to do this. The inner side of the knee is actually quite stable. It doesn't really pivot. The outer side of the knee, for various reasons, is unstable. And so the ACL's primary function is to stop the knee, if you look from the side, stop the knee from doing this. And you can actually see it on the model where I have the ACL here. And when it moves to the back, you can see that stretch right there. And so that when an athlete gets injured, what they actually feel is that their foot hits the ground and the knee pivots or buckles inward. So they feel like the knee buckles. What's actually happening is a rotational problem in the knee, which is giving that feeling like the knee buckles inwards. Interestingly, I have an old model that I've shown so many times in clinic. The ACL is actually torn because I continue to do this, and you can actually feel how much more unstable the outside of the knee is, even in the model. The inner side of the knee, for example, still stays pretty stable. So that is how an ACL is injured. That's what the ACL structure is. And now we'll dive in a little deeper onto some of the anatomy, what an MRI looks like, and what we do for surgery. So first of all, the mechanism again. One of the key take-homes that I'll continue to reiterate through this whole process is not everyone is created equal in tearing their ACL. There are risk factors completely. You hear a lot about maybe female or definitely young athletes cutting and pivoting sports. But there's other factors that also play into it that are listed here. Your core and your hip strength is important. Whether you're hamstring dominant or usually more quad dominant with weak hamstrings relative to the quads. And that's because it allows you to get up to speed, but the hamstrings are actually what slows you down. And since you can't slow down as much, that knee starts to do that rotational pivot. Poor mechanics. If you land with your knees bending inwards versus a nice square stable body, you're going to be much more likely to have that happen, because as the knee already gets into that buckling position landing, it's much easier to cause that shift. That's also what valgus knees. You see some people that are considered knock-kneed, which means their knees touch before their ankles, or versus bow-legged. Bow-legged is much more protective of an ACL injury. And then other weird things that we'll end up talking about, like the slope of the knee and things like this. But generally speaking, what happens is that the hip allows the femur to go in. So the femur is now not nice and square outside the body, but inside. And then this causes the tibia to rotate outward. And this buckling, what we call dynamic valgus, is what people feel when they say my knee buckled inwards. This is how you tear an ACL almost all the time, especially in young athletes. And we'll over time talk about why that's important and how we can mitigate those factors. So when we look at an MRI, we're going to have to get really familiar with looking at MRIs together because that's how we talk about these things. So this is a side view of the knee. So here's your kneecap in the front of the knee. This is the back of the knee. Here, the hips up that way, toes down that way. So to get you oriented. And the ACL is this big structure right in the middle here. You can see it's quite substantial and it connects the tibia up to the back end of the femur here. Now that's the side view, but it also orients itself so that it stops that pivoting shift around the knee joint. When we see an ACL tear, it's usually pretty clear. What we see from the normal here on the left with the nice fibers that are connected all the way, this would be an ACL tear that pulls off of the femur side. So you can actually see the fibers still look really good here, but as they come up, they don't make that connection back up to the back right there. So this would be a complete tear. It's a complete tear that's pulled off of the femur, and the MRI looks a lot different depending on the way you tear it. This, for example, would be one we could even talk about a repair. We'll talk about that later versus a reconstruction. So how it tears matters in our treatment. This is more of a classic MRI of a young athlete who they blow up their ACL. The energy put through the knee when they buckled was so substantial that it just kind of blew up. And so you see barely any fibers, and just a big gap where you used to have an ACL. This is why the ACLs don't really heal on their own. There's no bridging between there for you to even start to heal. These kind are the ones that continue to be unstable if not treated. When we talk about how the knee shifts on the outer side of the knee, what also happens, the big thing is that the tibia goes forward relative to the femur going backwards. That's what the ACL is stopping. So there's a classic bone bruise that we see on the outer side of the knee on the MRI that's shown here with the two red arrows. There you can see all this white bone bruising on both these sides here. That means for a split second, this knee shifted all the way back to hit to the back of the tibia. So if we see this on the MRI, even if someone doesn't show us the actual ACL fibers, we know that this patient has torn their ACL because the knee cannot shift to that extent where the bone here reaches all the way back to the bone here with the ACL still being intact. So that's a very important thing to be looking for. And some people can have cartilage injuries here, can impact the bone here. These are things in the more complicated cases that we'll end up talking about. When we look at the time of surgery, a normal ACL is this nice fan-shaped broad ligament. This is looking in the front of the knee. So here's the end of the femur, the top of the tibia, the foot's down towards the bottom, and the ACL is crossing the joint right here. And you can see this big band of fibers. Here's the PCL on the other side. They kind of cross by each other. So when we would feel this in surgery, we'd be very taut, like bowstring tight. And then when we get to an ACL tear, this would be more like that second one where we just have that big clump of tissue in the front of the knee. And you can again see there's nothing crossing up to the top of the knee. So this is what an acute ACL tear looks like at the time of surgery. When we do a reconstruction, essentially we're just trying to remake what was in there. We're trying to put a new piece of tissue across the bones to stop that pivoting. The way that this is done is we drill a hole into the tibia. This is the same view on this left-hand side. Drill a tunnel up into the tibia, drill a tunnel where it should go up into the femur, and bring new tissue across. Now, this is kind of step one of surgery. This is just day one. This is get the initial graft in. Now that has to heal, and we'll talk about all that. But you can see the concept is to just put a ligament back where there was a ligament before. If you get an MRI after an ACL reconstruction, which is not usually needed, but for various reasons sometimes happens, we can see that new tissue is crossing across the joint all the way up to the back. And if we compare that to a preoperative or an uninjured ACL, we can get the concept of surgery. We're trying to bring a bulk of tissue back across the knee joint where the previous ACL was. So relatively straightforward in concept, especially for a straightforward ACL, not a one with a lot of other complicating risk factors. So a big discussion that we have in clinic is the graft options. People have talked about this. If you're going through this, you've undoubtedly research this. You can scan this QR code that goes over a research article or a review article that goes over kind of all the graft options. The general take home is there's no single best graft option. If there was, we would just all do that one, but there's not. So there's different grafts. Risk factors play into it. How risky is this? A 40-year-old that tore their ACL is not the same as a 16-year-old who's on their second ACL tear. They're not even in the same category. We have to be much more aggressive about the 16-year-old. Other injuries like the meniscus, maybe they tore their MCL, maybe there's some other cartilage injuries around the knee, all of which have to be taken into account, or previous patellofemoral pain, previous patellar tendon injuries, things like this. The age and activity level play in is just severity, and then occupation. We don't want to do something that will cause someone to have kneeling pain if they're an electrician or lay tile or something like that. So lots of different options, or three main options in this setting. They all conceptually look the same. So you can see all the grafts still through a tunnel, crossing the knee, same thing. The most common are quad autograft, BTB autograft, bone patellar tendon bone, where we actually take some of your bone from your patella, a strip of your patellar tendon, and a little bit of bone on what we call the tibial tubercle, where the patellar tendon inserts, or hamstring autograft. And then there's a big category of allograft, which means not your own tissue. This is clean, sterilized, safe, but from someone, a human that has passed away, then we use their tissue. That's a good option in certain circumstances. It's our least used option, generally, especially in athletes. It's essentially not used in young athletes. And all of them have pros and cons. So I do all of them. I don't think it's right when a surgeon has one that they just always do, because there are different factors that you need to take into account. So long part of our discussion in clinic generally revolves around that. So make sure that you find a surgeon that is willing to have that conversation and kind of look at all of those factors. There are certain circumstances, a small percentage of people, ACL repair can be done. This is a very subset of patients where the ACL still looks good. It's just torn off of the femoral side. We don't do these off of the tibial side, and we don't do them if they tear in the middle. We tear them if we can attach it nicely back onto bone. And so what you see here is good ACL fibers, but there's separation. This should be up on the bone right there, and we can suture that and pull it back up, and even use what we call the bear implant, which you can look at, and we'll probably make a video about it at some point, which helps structure the collagen so that it gets a good healing environment to heal back to the bone. So ACL repair is an option instead of a reconstruction, with different pros and cons. It's a little more of a conversation than for this overview video. Recovery is long. This is why I think it's so important to know about this injury. This is why I'm making these videos. I will do my part if we work together on this. The therapist will do their part, but you are the most important person in the story for sure. This is your injury, and your recovery is very much dependent on how well you do with physical therapy. So physical therapy is about 9 months till full return to sports, okay? But it's very active during that period. So initially, the first about 3 months or so really is a protection phase. The graft actually weakens before it gets stronger. Your body uses that graft as a scaffold to make a new collagen orientation, to bring blood flow to the area, to get the graft to become a nice solid ligament that can tolerate cutting and pivoting athletics. So at first, we're just walking, we're getting the quads firing, and we're getting range of motion. First 6 weeks, you might be on an exercise bike, you're walking, you're working on the swelling. Icing is super important. Maximum protection phase, even for the first 3 months. Now, the reason we start with the mechanics of how an ACL is injured with the pivoting motion is because that educates us on what we can and cannot do after surgery. So what I call linear activities, running, front back activities, elliptical, row machines, stair steppers, hiking, anything where you go front back without getting into that risky buckling, pivoting position is really quite safe for the ACL. The ACL doesn't even work in those environments. So the first 3 months, we're really just doing that stuff, but you can do a lot of lifting, a lot of working out in the gym. It's still quite active. At about 6 months, we start to introduce some of the side-to-side cutting and pivoting athletics or activities, but in a controlled environment. What I tell people is it's very different if you jump side to side versus you're on a basketball cart guarding someone going side to side, because you don't know which way they're going to go. You don't have your muscles all set. You don't have the knowledge of which way it's going to happen so that you can get your body in a good position. But with physical therapy and in the gym, we can control those motions much better by yourself and take that stress off the ACL while starting to get your core and your hip and the rest of your knee waking up to returning to those activities. 9 months, typically when we evaluate for returning to sport, the graft is still healing. So it's well documented that 9 to 24 months, the graft is still healing, okay? So most re-tears happen in that sort of time frame between a year and 2 years as someone get back to sport. So there's some people that really just don't want to ever re-tear this again, and we push this 9 months out for sure. Because again, at 9 months, you're doing a lot of activities except for playing full speed cutting and pivoting sports. And so for someone like me, that's most of my life. I'm playing around with the kids, kicking the soccer ball, working out in the gym, but I'm not participating in high risk activities. So pretty much I'm doing everything that I want to do at 9 months. And if I were to start getting back to things like pickleball or skiing, I'd probably wait a year or so, just because I know the graft is still recovering. Now, a big thing that comes up is that all of this we need to take into account meniscus repairs, cartilage injuries. When someone has a simple routine ACL, it is a very different surgery than an ACL with a bad meniscus repair, a cartilage injury, other ligament injuries, or anything. They get the same headline if you're reading ESPN, ACL tear, but the ones that aren't getting back are the ones that had ACL tear plus these other things. And no one ever talks about the plus things. They always just talk about the ACL. ACL is pretty reliable getting back to activities. ACL plus all this stuff starts to become a longer recovery process and sometimes less reliable for getting back. So this is sort of the overview of ACL surgery. I'm going to dive in with videos on each portion more specifically. Again, I'm doing these for your education. The patients that I have that are more educated understand the fundamentals, even understand the anatomy and why we have to do physical therapy in a certain way. They are bought in. They understand their problem. They understand what's going on in their body. They understand why we can do certain things and can't do certain things, and why it feels weird when they do this or that. So this is critical if you're going to get an excellent outcome, to understand the problem, because ultimately it's your body. So this is the overview. We'll have some more videos, and I hope you found this educational as a start, but I encourage you to dive in deeper. And of course, always happy to help if you're in the Seattle area and would like to talk about your knee injury. Thanks for watching.